Good morning, everyone, and thanks, Dr. Khalid, for inviting me for this conference. And one disclaimer, as Dr. Khalid said, that I am a clinical hematologist, and amongst the audience of pathologists and flow cytometrists, I am the odd man out in this whole meeting. So I shall be discussing the MRD evaluation in hematological neoplasm, the clinician's perspective. And this MRD discussion will not be confined to leukemias, and it would be more into other disorders like that has come, like CLL, myeloma, and now lymphoma. So next. So I shall be discussing what's MRD and reviewing a brief outline of methods of its resection, examine the utility of MRD testing for assessment of disease in various hematological malignancies, and discuss various MRD-based treatment algorithms in clinical practice. That how do you translate this the information which you are getting on MRD? How does it help the clinician to change his treatment decision? How does it change the treatment plan altogether in patients? Next. Next. So MRD, as we all know, is sometimes called the molecular residual disease also, given to small numbers of cancer cells that remain in person either during or after treatment when the patient is in remission. So one of the important thing is that the patient is clinically in remission, but the disease is there, and it is applicable to any cancer, be it breast cancer, any cancer. This concept has been exploited. Primarily, it was developed with leukemias, and now it's coming more oncology diseases. Next. And it is strongly associated with cancer recurrence. So, even if the patient is in clinical remission and his counts are perfectly normal, he's behaving quite well, tolerating the therapy quite well, but his MRD is persistently coming positive at low grades, then we can simply prognosticate the patient that you are not going to do well. As your chemotherapy will get stopped, you are bound to relapse in near future. So many of such patients, so it is a way by which we can preemptively stratify or intensify the therapy for those who are having persistent MRD positive, and we can also de-escalate the therapy for those who are having persistently MRD negativity. There is no need to give a very high intensive chemotherapies for the patients who are having persistent MRD negativity. We can de-escalate. That reduces the treatment toxicity also. And so this, as you can see, the ideal situation would be that we give the cytoreductive therapy and the patient there is complete eradication of the cancer cell. But this doesn't happen in the practical situation. In the practical scenario, when you're giving a cytoreductive therapy, definitely the tumor burden, the cancer cells dip down, and then over a period they are detectable at a very residual level, and following which, when the intensity of chemotherapy decreases, then the disease again starts increasing. So this is the main crux of why we are doing MRD. So we are actually wanting to target this area when as a clinician we are satisfied that the patient is doing well, the counts are good, there's complete hematological recovery, but still if there is a disease at this point, then probably we need to intensify the treatment if he's persistently MRD positive. Next. So Professor Wood has very beautifully and elegantly explained all this. I won't be going into much detail. So this is the normal iceberg plot where you have this cartoon is showing that the morphological disease usually manifests when the tumor burden is more than 10 cells, and when this between this range, you see the measurable disease, which is not the clinician doesn't see. There is no clinical features, but the disease is there, and then the non-quantifiable measurable residual disease, and finally non-detectable disease. So there's the total spectrum how the cancer cell dynamics work, and based on this, we have different methods of detection. Histopathologist, the hematopathologist usually see this on the slide on the bone marrow, telling it that the bone marrow is in remission. But then we have other methods like flow cytometry, molecular real-time PCR, or next generation sequencing that are coming up in the detection of MRD. Next. So first is the flow cytometry. I won't be going into detail, and Professor Good has very beautifully explained all this, so I may skip this slide. And the second important method of detection of MRD is the the genetic methods for MRD quantification. It takes advantage of a natural process of immune receptor rearrangements or VDJ recombination, and it occurs in both T and T lymphoid cells. And this is now being comprehensively used in the West. Majority of clinical trials are now shifting from flow cytometry based approach to molecular approach now, and they feel that it is more sensitive. They can detect the MRD at a much lower level as compared to what can be done with the flow cytometry. Or they are also seeing it with rearranged immunoreceptors in B and T cells, which are amplified in each cancer cell. So this strategy is now being exploited in most of the research laboratories in the West. Next. So there are some pros and cons of different methods of detection of MRD. We have multicolor flow cytometry. We have qPCR for fusion genes, then ASO qPCR for immunoglobulin T cell receptor genes, and high throughput NGS. So you can see the sensitivity keeps on increasing as you go towards the NGS side. And the applicability, however, reduces when in our country, if you're talking about the Asian population, majority of the centers are still using to flow cytometry. Very few centers are using the molecular based MRD methods. How the basic review for using the flow cytometry is that it is very rapid, relatively inexpensive, and different from normal method, does not require access to diagnostic specimen. So this is something one of the basic advantage, I should say, that why majority of labs are using flow cytometry in Indian context. And the advantages of high throughput NGS or the molecular is that it is very sensitive, applicable to almost all patient, and clone unbiased, can track multiple clones and evolution. But the rider is that its widespread applicability is still a challenge in our country because the cost is exorbitant. The centers, the labs which are doing it are few, and the manpower is not well trained upon. And one of the most important limitation I always have in different forums, that suppose we are detecting an MRD 0.0001, should, as a clinician, I be changing the treatment based on that? It unnecessarily brings out fear in the patient's family that my child is still not free of cancer. So till the time we don't have a clinical trials to address this question, that what level of sensitivity we really require for MRD, and when we should intensify the treatment, when we should de-escalate the treatment, I feel we can definitely be using all these methods for research purpose, for generating our own data, but probably from the practical point of view, what really we should be doing as a clinician is something of matter of debate. So majority of the clinical trials, if you see, that they are not using NGS based MRD for changing or modifying the treatment. They are just collecting the data. Maybe they are not intensifying the patient, putting the patient into arm. Still, majority of the patient clinical trials are either using the flow cytometry or the molecular PCR based approach. Next. So different diseases have got different, in fact, we have 4 groups of diseases: myeloma, myeloid leukemia, lymphocytic leukemia, and lymphoblastic leukemia. And in all 4 diseases, the MRD is being used. But definitely ALL was the one disease where we reached to the level where the sensitivity, we have almost reached to the sensitivity of 0.01%, even less than 0.01. Basically, the main reason is that the maturation pattern of precursor B lymphocyte is so well defined that you can easily identify the neoplastic clone from the normal population, and that's why this ALL MRD gained significance. But now, as more and more we are advancing, we have got a well-established myeloma MRD also, CLL MRD also, and AML MRD also. Next. So current role of MRD assessment in clinical care comprises of, first is the patient risk stratification. I would say that independent of molecular risk factor, if I am being asked as a clinician, what is the single most factor which you will take into consideration while risk stratifying a patient of ALL or AML, I would say that it's MRD, because that gives 2 information. One is definitely that the disease is resistant, and the second is also that it's a resistant nature of the disease. So you have given a chemotherapy for around a month, and the patient is still MRD positive. Definitely, it gives you an indication that this patient is not going to do well, even if he is a favorable risk on molecular profile, but his MRD is turning out to be positive, then I would be escalating the treatment. So that's the significance of MRD. It's the single most independent predictor of prognosis in patients of acute leukemias. The second is the prognosis after initial treatment, after throughout treatment, selection of patients for treatment intensification, and prediction of long-term outcomes. So, Professor Wood discussed this study, and this was a landmark paper. I'm discussing this AL0232 because this was one of the pioneer trials for pediatric ALLs. They comprise the data of 2,400 odd children, and it was a BFM backbone protocol, COG protocol. Next. And they clearly showed that the level of MRD at the end of induction is directly proportional to the event-free survival. So if you have a lower MRD, the better the outcome at 3 years. And you can see in both the plots, even both the event-free survival as well as the overall free survival. The various cutoffs for MRD have been used, less than 0.01, then 0.01 to 0.1, 0.1 to 1%, 1% to 10%, and more than 10%. And you can see that very beautifully the plots are separating out. So there is no doubt about it that probably this is the way that every center who's treating ALL at their respective should be going for an MRD analysis at the end of induction. Next. And these time points are even informative at the end of consolidation, and they have shown that the patients who were MRD positive at the day 29, but at the end of consolidation, they turned MRD negative, then also there is a distinct separation of the curves. So if MRD less than 0.01 versus MRD more than 0.01%, you can see there is a sharp difference. So definitely at every time point after induction, then after consolidation, it has got its own significance. Next. And there's the molecular way of quantifying MRD, and you can see that the MRD quantified by ASO-PSCR and still at different time points, day plus 24, week 22, and week 52. At every time point, you can see that the curves are very beautifully separating out. The disease-free survival is very good for patients who are MRD negative vis-a-vis who are MRD positive. Next. Now, another important thing is, as a clinician, we usually avoid taking patients for transplant who are MRD positive. We try to bring them to MRD negative state before bringing, and numerous studies have been shown that if you are taking a MRD positive patient for transplant, probably the outcome is not that good. So in Indian scenario where the patient is spending so much of money for the transplant, they are arranging the money because there's very little government aid. So at that point of time, we first counsel the patient also, as well as we try to give some sort of chemotherapy with new molecules coming like Blincyto and inotuzumab. We are using those therapy to bring the patient to MRD negative state prior to taking for transplant. And this has been shown in the data. And even post-transplant also, if the patient is MRD positive at day 100, then the outcome is bleak as compared to patients who have MRD negative state. Next. So just a treatment algorithm in ALL based on MRD. So this is one of the algorithms being used by majority of centers across the world, and they stratify the patients into standard risk and high risk based on the molecular markers. And then they usually give the chemotherapy. At the end of induction, they do a MRD. Then at the end of consolidation, they again do the MRD analysis both in standard risk as well as in the high risk. The high risk patients are usually SCT eligible because we are going with the haplo as well as the mass sibling donor transplant. So if the patient is MRD positive, this molecule has come a big way, Blincyto. We have added this into treatment algorithm. So we try to bring the patient to MRD negative state before taking him for transplant. So this is a new addition. So you can see here that based on the MRD, we are changing our treatment decisions. We are intensifying the treatment based on the MRD. So if the patient is MRD negative, no need for any chemotherapy. We straight away take for LOSCT. But if it's MRD positive, then we try to bring him to MRD negative state before taking the patient for transplant. Even if after Blincyto the patient remains MRD positive, then probably we take him and we prognosticate the family that probably the chances of relapse post transplants are quite high. Next. Now, this is the outcome of MRD in AML, and here also the cutoff for MRD was 0.1%, and this was Professor Wood's lab, I think. Professor Wood's paper lab has published emphatically in JCO that the relation of clinical response and MRD in AML, and he's shown that this MRD positivity is associated with poor survival. Next. Now, again, MRD in AML, again, the treatment algorithm has changed and based on the MRD level. So you can see that we give the first cycle of induction chemotherapy, we monitor for the MRD. If MRD is turning out to be positive, then we think of some other targeted therapy. So this is one of the important thing that has entered into our treatment algorithms now. So MRD, based on MRD, we are deciding whether the patient is going to respond to the conventional chemotherapy arm or we have to try something different, because now a lot of targeted therapies are coming in AML also based on the molecular subtype. So cycle 1 we give, then measure the MRD, then we give the cycle 2. If the patient still remains MRD positive, then we go for a transplant, but the transplant conditioning is also being decided by the nature of MRD. You can think that how we are changing the decision. So if here the MRD is positive, then we never ever think of doing a RIC transplant, reduced intensity conditioning. We will be going for a myeloablative conditioning, a more intensified conditioning. While if the patient is MRD negative, then probably we will be opting for a RIC conditioning, which is less toxic to the patient, especially for the age group like more than 50 years. So that's how we are always changing. And see, similarly, post-transplant also, based on the MRD, we are changing the decision whether to give the maintenance therapy post-transplant. For example, in FLT3 ITD positive AMLs, when we are doing the transplant routinely, now if the patient is remaining MRD negative, then we can wait. Why to start sorafenib just immediately after transplant? Because it has got its own toxicity. The risk of viral reactivation is high. So just based on MRD, it's a very good guide for us to modulate the treatment based on that. Next. Another disease which usually doesn't take our is CML. Actually, BCR-ABL is a sort of MRD only. We are changing the TKIs based on the BCR-ABL transcript, and based on that percentage, we decide whether the patient is responding to TKI or not. So it's a sort of a molecular MRD which we are using in, day out in our patients. And based on the BCR, if the patient hasn't attained an MMR, major molecular response in CML, then probably if he is MRD positive, you would call it, in other words, he's MRD positive, and you need to change the TKI based on those reports. So it's very important that either be a molecular or by flow, MRD holds its significance in each and every hematological disorder. Next. When it comes to chronic lymphocytic leukemia, then again MRD is one of the important thing. You can see that the molecular MRD has been done, and with patients who have a less than 10⁻⁻⁴ MRD has the best survival in CLL as compared to the patients who are having a positive MRD. The basic idea of CLL, the MRD coming in CLL, is because now we have dissected out the molecular subtypes of CLL. Every CLL is not the same. Like, for example, 17p deletion CLL is far different from other CLLs, and they have a tendency to be more aggressive, and many times they progress to a high-grade lymphoma also. So there comes the role of why we should be doing or subjecting the patient to MRD in CLL also. And apart from that, we can prognosticate the patients with the venetoclax also coming in CLL, fludarabine venetoclax regimen that is being pushed into the CLL. Now more and more clinicians are subjecting their patients for MRD in CLL. Yes. Next. And this not in our country, the transplant is not really being done too much in CLL, but still it has got a prognostic significance in CLL post-transplant also. Next. Myeloma is another important thing. That's the Mayo's Clinic data, and they have emphatically shown that all the patients, one important debate is what should be the treatment endpoint for multiple myeloma. As we all know that myeloma is an incurable disease. Now, if it's an incurable disease, what should be the treatment endpoint? Many clinicians feel that MRD negativity is the point where you think that the patient can be put into on maintenance therapy and he can enjoy his life. There is no further need for any further therapy. Just keep him on low-grade maintenance therapy and monitor the MRD. So the algorithms are changing now. It was not prior when MRD was not there in myeloma. Every patient used to go for a transplant, and still patients are going for a transplant, but with the daratumumab BiTEs coming into clinical picture, really MRD is one of the things which determines whether really the patient needs a transplant at that point of time. If he's MRD negative, then you can wait and watch. Why to cause so much of toxicity in the patient, just subjecting them for transplant? So that's one of the treatment endpoints now it has become for myeloma, and this has been emphatically shown by the Mayo's experience. Next. So they analyzed the MRD by NGS, and they have shown that the different MRD levels have a direct impact on the median survival, 80 months, 45 months, and 27 months, and they are all statistically significant, both overall survival as well as the time to progression. Next. Another area of research is non-Hodgkin's lymphoma. Now, this is something now it is evolving. It hasn't come into routine clinical labs, but now cell-free DNA is now coming, and it's also a type of an MRD analysis only. Earlier, what we used to do is we used to just monitor the patients of lymphoma by doing a whole body PET-CT, and PET-CT used to give us a prognostic significance. Yeah, this is a patient who's going to do bad. He hasn't achieved. There's a partial response or progression or something like that. But now it is coming into the non-Hodgkin's domain also, and by doing the cell-free DNA in the among the tumor cell. And this is a NGS-based approach is also being applied by immunoglobulin high throughput sequencing. Next. And this you can see that how beautifully it has shown that even the PET-CT is inferior to the MRD analysis in non-Hodgkin's lymphoma. You can predict the patient apart from the cell of origin, which tells you that this patient is not going to do well or this going to need some intensive therapy. Just by the MRD, you can find out that you need to intensify your therapy. So you can imagine maybe after 5 years from now, rather than doing a PET-CT or maybe that PET-CT in the interim PET, rather than doing an interim PET, we might be going for an MRD analysis and determining whether we need to change the treatment or not, whether we need to intensify the treatment or we need to continue the same treatment. And this shows the NGS-based retrospective analysis of 108 patients on 3 treatment protocols, and circulating tumor DNA was drawn on day 1 of cycle 3, and they have shown beautifully that the time of progression is different among, and it is directly proportional to the overall survival in non-Hodgkin's lymphoma. I think Dr. Khalek is doing a project also on cell-free tumor DNA as a part of an MRD analysis in non-Hodgkin's lymphoma. Next. So, summary of MRD in lymphoid malignancies, multiple assessment methods available, flow cytometry, quantitative ASO-PCR, and NGS quantification. Each of them have their own significance. MRD levels are prognostic for relapse-free and overall survival. Next. And MRD as a surrogate endpoint should be a surrogate endpoint in all clinical trials now. In majority of hematological neoplasm, MRD is coming a big way, and we should be that should be an endpoint of our treatment efficacy also. Whether the patient is really achieving an MRD negative state, and whether you should escalate or de-escalate the treatment protocols based on MRD. The timing of MRD sampling and repeat assessment, there is bit of not so much of clarity at which exactly time point should you be doing apart from the leukemias in other diseases like CLL and myelomas. Outcomes of treatment at MRD progression versus clinical progression, and timing of treatment for progression and toxicity. These are my references. Thanks.